thanks. So welcome to this presentation, which is entitled Genomics in Ovarian Cancer. My name is Dr. Rosemary Lord. I'm a medical oncologist at Clatterbridge Cancer Centre, and my colleague is Dr. Rachel Hart. I'll just let you introduce yourself.
Hi, I'm Rachel Hart. I'm a consultant in clinical genetics, and I work mainly in cancer genetics. So I work with the team at CCSC, but also across the region in Manchester and Lancs and South Cumbria too.
Thanks, Rachel. So we're going to move on to a little bit of a general discussion around ovarian cancer and the sort of testing we look at, genomics and genetic testing for patients presenting for ovarian cancer, and why we do that, at what time point in their clinical history, and also how that impacts our treatment and decision making. And I think Rachel is then going to go on to cover some of the wider discussions around genetic testing. Next slide, please. Thank you. So this is a general slide around presentation for ovarian cancer. We see about 7,000 new patients each year in the UK. Patients are often presenting with quite non-specific symptoms such as bloating, change in bowel habit, loss of appetite, weight loss and fatigue. And they do undergo a number of investigations, including blood tests, imaging with ultrasounds and CT scans, and ultimately histological testing either through biopsies or surgical sampling. We can see from this chart that the incidence does increase by age. It peaks in the 70s. And then we do have some younger presentations, and we often associate these more likely with genetic type ovarian cancers. Next slide, please. This figure really just shows the importance of trying to detect the cancer at an earlier stage for the best outcomes possible. Unfortunately, only a small number of ovarian cancers are diagnosed at stage 1 and 2 disease. We can see at this stage the 5-year survival is significantly better than for presentation at stage 3 and 4. Sadly, the majority of our patients do present with advanced stage disease. Slide, please. So ovarian cancer isn't just one disease. Epithelial ovarian cancer accounts for over 90% of the ovarian cancers that are diagnosed, with only 10% being non-epithelial. Of the epithelial component, high-grade serous is by far and away the most common type of ovarian cancer. And these are the ones that we typically think about that have the molecular alterations such as BRCA1 and 2, p53 mutations, and those with homologous recombination repair deficiencies. The other subtypes tend to have different molecular patterns, as can be seen on this slide here. Next slide, please. This is just another way of depicting that, really. In the serous ovarian cancers, we see this split of BRCA type pictures, with the BRCA1 and the BRCA2 germline mutations accounting for somewhere between 10 and 15% of serous ovarian cancer types, and somatic mutations a smaller but significant percentage. And these are the area we're really sort of focusing in on today's discussion, really. Next slide, please. So for all our patients with a high-grade ovarian cancer who present to the medical oncology clinic, we consider testing to see with the R207 gene panel test, which goes to the GLH lab. This is a blood test, a germline test, to determine whether there's a hereditary component to the ovarian cancer. We specifically look at the BRCA1 and 2 genes, BRIP, also MLH1, MSH2, and MSH6, and the RAD51 genes as well. And these are the ones we specifically look at. The main results of abnormality we tend to see in ovarian cancer are BRCA1 and BRCA2 gene mutations. We do occasionally see BRIP1 and less so the other gene mutations, but this is the panel test that can be done on the blood sampling, and this is offered to all our patients who come through the ovarian cancer clinic. Ideally, this should be offered to all high-grade ovarian cancer patients. We do that within our clinic as mainstreaming, but this may not be the same across the country. I think we can perhaps pick up on that discussion with Rachel at the end of the presentation. Thank you. Next slide. The other thing we look at testing our patients with high-grade ovarian cancer is some tumour testing for homologous recombination deficiency and somatic BRCA. The main reason for this is that it really does direct potential treatment options, and particularly thinking about a medication called PARP inhibitor therapy, which is particularly effective for patients who harbour BRCA mutations or homologous recombination deficiency. This diagram tries to demonstrate how PARP inhibitors work. PARP inhibitors prevent repair of single-stranded DNA breaks and leads to an accumulation of double-stranded DNA breaks. In those cells that have homologous recombination deficiency, such as BRCA mutated cells, these double-stranded breaks cannot be repaired and leads ultimately to cell death. So it can be considered a kind of targeted therapy in this situation. So we know that PARP inhibitors exploit this homologous recombination deficiency. So understanding which patients have this can really change the treatment options and outcomes for patients. Next slide, please. So this is really just represents the profile of the HRD testing, which essentially looks at genomic instability or genomic scarring, and uses a score combined from these three tests, which are demonstrated on this slide here, and provide a score which ultimately then is reported to us as either the patient being homologous recombination deficient or proficient. Thank you. Next slide. So in summary, the two things we really look at are the tumour testing for the HRD and the somatic BRCA testing, and the R207 hereditary gene panel test. So I thought I would just, at the end of this presentation now, do a case presentation of a typical, if there is a typical case, but one which hopefully sort of looks at the time points in which we might undertake these tests and the implications for our clinical decision making. So this is a case of a 68-year-old female who presents with abdominal bloating and altered bowel habit for 6 to 8 weeks. They've been noted to have a blood test with a raised CA125 level, and they've undergone scans which have confirmed the presence of ovarian masses and mental and peritoneal disease, which equates to a FIGO stage 3C ovarian cancer. She underwent CT-guided biopsy, which has confirmed the presence of high-grade serous ovarian cancer, P53 mutation on immunohistochemical testing. The patient's case has been referred through the specialist MDT, and they've recommended that as a first treatment, they would undergo primary surgery with a view to subsequent adjuvant systemic anti-cancer treatment. Next slide, please. Following surgery and complete debulking, the patient has been referred to our clinic in medical oncology to discuss ongoing treatment options. So at this stage, we recommend chemotherapy and targeted anti-cancer therapies as this first-line treatment. During this initial consultation, we will also undertake a a limited family history, and it was established that this lady's mother had breast cancer in her 60s. She doesn't have any siblings, and her paternal cancer history is unknown. As discussed earlier, we offer the R207 gene panel test as routine, based on the fact that we think about 10 to 15% of these types of cancer can harbour a BRCA gene alteration. And this is discussed in clinic with the patient. A record of this discussion and the implications for this test are noted, and we supply supporting information to support that discussion. There's a number of options of resources that we use for this. We particularly use the Eve charity information on genetic testing, but there's plenty of resources from other charities, including Overcome, who provide information that can be used to support patients. This sample is then sent off from clinic, which goes off to the GLH to be tested. Next slide, please. We also discuss the tumour testing, the genomic testing, looking at somatic BRCA and the HRD testing. We explain that the rationale for this is to try and direct treatment and offer targeted therapies. This request is sent to the path lab for sample processing and subsequently transferred to the GLH for testing. Rachel can correct me if I'm wrong, but I think currently we usually wait for about 2 to 4 weeks for the HRD and somatic BRCA testing results, and the R207 test usually, on average, I would say takes about 6 weeks. These timeframes are improving quite rapidly, but they're usually available by the time we review the patients after 3 cycles of treatment. So this patient was started on a combination chemotherapy treatment of carboplatin and paclitaxel with the addition of a targeted treatment called bevacizumab, the plan being for up to 6 cycles of treatment. So following 3 cycles, we do have these results available. We have the HRD and the somatic BRCA test results, which show that the patient has a somatic BRCA1 mutation, and is HRD positive with a score of 0.64. On our testing, anything over 0.5 indicates homologous recombination deficiency. The R207 panel test has not shown any abnormality, and therefore it would appear this patient has a somatic BRCA1 mutation and not a hereditary germline alteration. At the end of treatment, after 6 cycles of treatment, we then discuss the ongoing maintenance treatment, which consists of continuation of the bevacizumab for 15 months, and also the addition of olaparib, which is a PARP inhibitor, which can continue for up to 2 years. So please. So a few things I wanted to discuss here really are, we have undertaken this testing and managed to make treatment decisions, but really, do we have opportunities to get these results at an earlier stage and make sure we know what treatment should look like from the outset. So we do have opportunities for earlier testing. This could be done on either the diagnostic biopsy, which is often taken at local diagnostic units. And the question is, should we be considering reflex testing as we do for Lynch testing currently? The other time point is, could this be done from the surgical debulking or the primary surgery, where the sample could be sent off directly from the specialist surgical centre? There are significant benefits to earlier testing. It would mean that potentially these results would be available to us by the time we see the patient to discuss their systemic anti-cancer treatment. We can make earlier recommendations for the patient pathway. And also it potentially means that we would not overtreat the patients. We, due to the constraints of prescribing for some of our targeted therapies, we do have to start these treatments and actually then stop them based on the results of the HRD testing. So to have this up front means we would be able to make much more personalised decisions for the patient and give them the best treatment from the outset. And then, the other question to think about is, should this patient be referred for a subsequent genetic opinion based on her family history? We know we haven't seen anything on the R207 panel test, but with a history of breast cancer, does that, mean we should consider genetic referrals? So I think at that point, I'll hand over to Rachel so she can have a little discussion about. We wouldn't normally do that unless we had other concerns, but I'll hand over to Rachel, who might be able to expand on some of the discussions we've opened up there.
Thank you, Rosie. And I think in this particular case, you probably wouldn't be referring through to clinical genetics. That would be a decision made on any further information that patient brought forward that would expand that family history. But based on her and her mother alone, that wouldn't meet testing criteria. But that leads me on to what I wanted to say. And what I want to say is that you're not on your own. So what Rosie's talking about here is what we've started calling mainstream genomic testing. And this is about personalising a patient's treatment. This is not about clinical genetics not wanting to do genetic testing. It's about trying to get testing that's relevant to the patient at as early or at as appropriate place in that patient journey as possible. And the reason we want to do that is if there is a way to target their treatment because there's something available out there, then we want to make sure that they can get that. We want that equity across the whole country. And by streamlining things, we can get that equity. So whether you present in Bognor Regis or Chester, you're going to get the same sort of access to treatments. Easier said than done, but that would be an aim, certainly to genetic testing. So mainstream genomic testing is about personalising treatment. It is also subject to change. So I think part of thinking about pathways around genetic testing is also thinking about how those conversations flow. So if there are changes that need to be given to teams who are doing that genetic testing, there needs to be a two-way conversation about how that happens. So at the moment, information is sent out around the region via the GLH if there are updates or changes in genetic information, or via the GMSA. But sometimes there needs a bit more granularity to that. So having some kind of MDT or conversation with your local genetics team is also really, really important. I think the other thing I wanted to point out is somatic testing does not require consent. It makes sense to have a conversation with somebody about, we're going to do some more tests on your sample, but you do that all the time. That particular somatic testing, the IHC and the HRD, does not require consent. It's a tissue test. It's not a diagnostic test. Germline testing is not as onerous as I think some people feel. We are working on ways for better embedding request and receiving of results. But at the moment, the oncologists, as Rosie says, do R207 testing when they see patients, but we know there are patients who never go to oncology, and we know there are patients who could benefit from having their testing at an earlier stage. So I think if possible, it would be really valuable to look at moving that pathway of genomic testing a little earlier into the patient pathway, and as a region finding out how we can do this. It works in other regions around the country, so maybe that's a conversation that we can start to have. And I think the other thing to remember is that most results will be straightforward. Most results are going to be very clearly they don't have something or they do have something, and in most cases there's no genetic change. But when they do have a gene change, then that is where the patient then gets referred to clinical genetics, because we should be seeing all patients with germline changes for a variety of reasons. Number one, we want to explain to them what this is all about. Number two, we want to make sure they get the right screening for themselves. And number three, we want to ensure we cascade that screening out to their relatives. We know around 1 in 350 people will have a BRCA mutation, and we don't see anywhere near that number. If we can identify patients before they develop a cancer, we can get them into appropriate screening programs. So the push really around mainstream genomic testing is around supporting women who have breast or ovarian cancer to get the appropriate testing, but also to support their families to get seen and identified prior to developing a cancer. And for discussion of results, the local genetics teams are very happy to discuss results with you, and then obviously see family members, see their individual. The GLH also, so that's the Genomic Laboratory Hub that's hosted at MFT, hold a GTAB, a Genomic Tumour Advisory Board, and that is for solid tumours. So if you have a query about a result around tumour testing, that's where the conversation goes to. You put in an application and they talk about it there. If you have a result that's around an inherited cancer predisposition, that goes into a different GTAB. But again, it's very easy. Fill in the form, the lab will decide where it goes to, and it can be discussed. You come along to that meeting to hear the discussion, and you get that information to take back firsthand to your team or to whoever, to your patient, etc. So finally, just want to let you know that what the role of clinical genetics is, and I think I've sort of said that already, but we are there to diagnose, support, counsel families with known inherited disorders or even with possible inherited disorders. So for those patients where you've had no positive genetic result back, but there's still young onset ovarian cancers, or there's multiple cancers within that family, or an individual with multiple tumours themselves, we would still see them even if you've had a negative BRCA test or even a negative R207 test. So we do we have lots of up-to-date information. We are involved with national and international groups around redefining some of the changes around these genes, and we look to support individuals of any age with these conditions. There is a national cancer predisposition registry being developed. We already have a very high-risk breast screening registry, so anybody who is identified through ovarian testing with having a BRCA mutation would be sent to us, and we would put them into the very high-risk breast screening and talk to them about other options available to them. Anyone with ovarian due to a Lynch syndrome, again, we put into the National Lynch portal, and they get their screening through the National Bowel Screening Programme, plus other screening they may need to have put in place will be arranged by ourselves. So we're still very much there to do the multi-system support of your patient once you've identified that they've got a genetic condition. So there are two teams in our region. So there's Cheshire and Merseyside, which covers Cheshire, Merseyside, the Isle of Man, and we sit in Liverpool Women's Hospital. Our website is there. And there's a Greater Manchester and North West region, which is served by Manchester Centre for Genomic Medicine. So that's all I wanted to talk about. Rosie, did you want to come in with anything more?
No, I think that was really helpful. Thank you. I think people, just to re-emphasize that people do often worry about how difficult mainstream germline testing is, but we've integrated it into our practice now for probably 6 to 8 years, and actually it's really beneficial, and I'd like to say straightforward with the support of the genomic, with your service. And yeah, I think we'd want to encourage, as you say, making that done as early as possible, so we do catch those patients who don't actually come through medical oncology. We know that about 20% of patients are never well enough to actually come to us for treatment, and I feel we do need to think about how we capture those other patients.
Thank you, Rosie. And there is a drive through the Northwest GMSA to look at mainstreaming and how we can support services to do testing at an earlier stage. So there will be more around this. But in the interim, if you're interested, please feel free to contact your clinical genetics services if you want a bit of extra support. There's lots of advice and guidance out there.